So before I hand it over to Marianne Cisco, I want to introduce Marianne to you. Marianne has enjoyed a long and celebrated career in hospitals, rehabilitation centers, orthopedic clinics, and most recently at the Upledger Institute, incorporating craniosacral therapy, visceral manipulation, and mechanical link in her work to improve functional outcomes and relieve pain. In 1988, the University of New Mexico named Marianne their first Clinical Educator of the Year. Marianne is an international instructor for the Upledger Institute International and teaches on average 20 seminars across US, Canada, and internationally each year. Over the past 20 years, Marianne has also been a featured speaker at numerous national and state conferences for the American Physical Therapy Association, the American Massage Therapy Association, Compass Massage and Bodywork World of Wellness, and more. Marianne Cisco is passionate about helping people solve even the most puzzling issues. Once struggling with her own health challenges that didn't respond to conventional care, Marianne discovered the guiding principles of craniosacral therapy and other osteopathic approaches, and finally experienced hope in healing. Fueled by her personal belief that you cannot diagnose the power of human spirit, Marianne now delights in sharing her skills with her patients and students alike. So with that, I am going to stop my share screen and admit the few others in the waiting room here. And we'll hand it over to Marianne to begin. Thank you so much, Marianne. And the floor is yours. Thank you.
Okay, I think I've got that. Welcome everyone. Thank you for spending part of your evening, if you're here in the United States, or whatever time it is around the world where you are seeing this presentation. I wanted to share, first of all, a little bit about my intention with this particular presentation. My intention is to really help people understand the complexity of concussion beyond the hit on the head. The hit on the head changes the metabolic balance within the brain, and an inflammatory response ensues, and neurons and axons die, and the messages that they send become dysfunctional. And this can result in sequelae or symptoms that persist past the actual concussion, long past the actual concussion. And sometimes they may not appear till months and sometimes years later. And most importantly, what I want to convey to all of you, my colleagues, is that we offer hope to people who are suffering from persistent concussion symptoms. And we do this through the addition of manual therapy. And what we are talking about specifically now will be craniosacral therapy. Again, thank you so much for being here. We're going to start. So Justin, my PowerPoint is not advancing. There it goes. All right. So here we're going to begin with a little poll that I like to take during these presentations. And the question is, have you yourself had a concussion? And if you could just go ahead and answer that.
A lot of questions, or a lot of answers coming in here, Marianne. Should just
Yeah,
keep.
see that. And it's just about split in half. All right, many times these presentations have a large percentage of therapists who have had a concussion. So basically it's 90%, 90 people out of the 181 and have had a concussion, and 90 have had a concussion and 91 have not. So we are basically split down the middle here. Okay, so you can see that. And then let's go to our next question. Justin, I'm having a problem with my.
No. Did you click, will you click on just where it says like question 1 and see if that'll fix it for you, Marianne? Sometimes it'll just be a matter of getting control back to the PowerPoint.
I don't even see where that would be. Question 1. It's got
Just on the PowerPoint itself, the InTouch slide that you have up. If you just click anywhere on the slide, sometimes that'll just give the power back to your PowerPoint.
Oh, I see. Okay.
Cool.
All right. So here, the question is, if you answered yes, do you have ongoing symptoms? So we have about, I'm going to go ahead and end the poll. Looks like everybody answered. And we have 38 people out of those 91 that are still experiencing some symptoms and 66 who do not. Okay, so thank you for sharing that. You can see those results. Okay, and then let's move on to, this is our last question. If you yourself have not had a concussion, so if you did not answer yes, are you close to someone who has had a concussion and continues to have symptoms? So this could be a loved one, a friend, a family member. Okay, that looks pretty strong. 93 out of 42 in that group. So about 68% of those who have not had a concussion know of someone that does. All right, and then we've got about 32% that do not. Okay, all right, so thank you everyone for answering those questions. I want to go over a little bit about the incidence. And the data for this is all over the map. There is not a whole lot of consistency. So what I settled on here is that the incidence is by the data is about 3.8 million per year in the United States. And those current data sources, though, it has been estimated that they account for only 1 concussion out of every 9. And so the actual incidence is much higher. And if we go and look at the research done in the UK and Wales, there the research showed that the patients that were hospitalized after a major physical trauma, that 68% of them were suffering from a concussion. And their research showed that young men and older women are at the highest risk for concussion. And also in the UK and Wales, they found that falls are the most common mechanism for concussion and account for the majority of the concussions in the very young, less than 15 years, and in the population that is older than 65. And the causes of concussion are falls, which we've just looked at, And motor vehicle accidents, these depend, of course, on the force and the complexity of the car accident. And sports related, there's many concussions that occur because of sports. Here in the United States, our most popular sport is American football, and that has generated a lot of press and concern and research in helping to reduce the incidence of concussions. However, in other countries, American football the popularity of it anyway, is replaced with other sports. So if we look at our neighbors to the north in Canada, they love their hockey, and our people in the European Union, okay, love soccer. And in Japan and other areas of Asia, the mixed martial arts are very popular: wrestling, boxing, judo, karate, kickboxing. And then Australia has their game of football that goes by different rules. Ireland is replaced with rugby. And in New Zealand, interestingly enough, they have found that 31% of the population has had a concussion from a sport, any sport, all sports are represented, by age 25. Okay, and some of these organizations are trying to decrease the incidence of concussion. And the Rugby Association in 2019 implemented new rules where they could no longer tackle an opponent at the neck or the head. And after that was implemented, they noticed a 37% decrease in concussions as a result of the tackle. And some of the other sports associations are also changing some of the rules. And just to return to our causes of concussions, besides sports related, there can be assaults and also blast injuries that can be typical with military personnel. And who is at risk for a concussion? This includes someone who is over 65 or under 5 years of age. These are primarily related to falls. Adolescents due to bicycle accidents and sports. So this would take into account those individuals when we looked at that research from the UK of 15 and younger would fall into this category of adolescents. Military personnel secondary to blast injuries. And motor vehicle accidents, again, depending on the speed, the force, the complexity. Did it roll? Was there a seatbelt or not? There's many variables there. And physical assaults, these can be from a stranger or they can be domestic abuse. And then also, who is at risk for a concussion includes people who have had a previous concussion. Okay, so these concussive symptoms, when there is a concussion, the vast majority do recover, all right? And they recover somewhere between 2 to 3 weeks, sometimes longer. They become diagnosed as persistent after 3 months, and other causes have been ruled out for those persistent symptoms. And so they occur in about 10 to 15% of concussed individuals. And we saw in our polling that we took that we do have attendees this evening who are continuing to experience symptoms associated with their concussion. All right, so what I would like to ask you to do is I'm going to be showing you 3 still shots of an actual concussion happening from 3 different sports. And what I would like for you to do is, besides the seeing that there's an actual concussion taking place, I would like for you to see if you can identify another common denominator that is occurring at the same time as the concussion. All right, so we'll start with the soccer. And then next, we will look at this rugby picture, this image we looked at before. And then here's our last image of a football player. All right. Okay, so let's go back and look at this. Justin, is there a way for people to respond in the chat box, or has that been disabled?
The chat is open, so anybody.
Yeah, if anybody would like to answer what the common denominator is, just to get an idea of some of the answers.
Somebody that typed in vector, force to the head, whiplash, neck injuries, eyes closed, head and neck connection, neck injuries, no helmet. There's always more than one person involved. Compression of neck, torsion of torso and shoulder, movement and preparation for the impact, temporal, blunt trauma to the head, impact, sports.
Okay, great. Okay, well, thank you everyone for responding. And yes, you have noticed the detail. And what I would like for you to be aware of here is that also part of putting that together from a craniosacral perspective is that the common denominator is that this is a whole body event. And all of you did identify that. And what is interesting here, and this is one of the reasons why craniosacral therapy is so helpful, is because it honors and is listening to the uniqueness of each individual. And we'll just take a brief look here, and you noticed many of these, but when we look at this picture, you do see this concussion happening head to head. When we look at the ball here, this particular player is getting an oblique, she's being hit from behind obliquely with the ball. We don't know how fast that ball is hitting the head, the speed at which, because that also tells us about the concussion. And then when you look at the other player, this she is getting a superior compression obliquely. Let me see here, along this line. And then notice that her right arm of this player is abducted to maybe 40 degrees. And this arm is extended, and this portion of her arm is being hit by her opponent's shoulder, and her opponent's shoulder is making contact and being hit by this part of her shoulder. And we'll also mention the rotation of the trunk that is occurring. And we've got the pelvis here. We can get a glimpse of that is rotated posteriorly. And so when we see this whole body event, we think of what we learned in Cranial 2, which is the regional tissue release. And in SER1, where there was further explanation from Dr. Upledger's theories about the trajectories of just in a split second portions of those packets of physical trauma are being transported into the body. And we, as practitioners, find these positions when we have, while we're working with regional tissue release, with our cue from the craniosacral rhythm, the significance detector, or the SD. And you can see how this person's hit is different than this one. Okay, this one, he's getting looks like the person with the helmet is getting causing an oblique hit, okay, from the back over here into the right frontal area. You see his shoulder, which looks very muscular, is also giving him a lateral hit right through the temporal bone and the temporal mandibular joint. Then this entire, well, not the entire arm, but certainly the upper arm here is basically hitting the anterior neck. And while this moment in time of this concussion is happening, you see the player in red has his arm close to his side. He's at 90 degrees. He's clutching a ball. We are going to feel all of these when we are working with regional tissue release. Then if we come here to the football player, you see he's definitely getting compression, and he was or has been somehow suspended in the air. You see his leg is up here, and he's got a bit of a superior and lateral hit that is compressed. And while he's having that compression force enter his body, you see the position of his shoulder and his wrist clutching the ball. And again, we're going to feel all of these movements and be able to help people by honoring their particular uniqueness of their injury, because they've all had a concussion, but you see that it's very different from a physical standpoint. And the other thing with this whole body event is that you and I have the whole body evaluation in which to be able to listen to the inner physicians telling us what is a problem at that particular moment in time through our arcing for energy cysts, the listening stations, our dural tube traction, helping us find those facilitated segments, and the fascial glide, as well as the listening stations, help us to find these tensions in the body's soft tissues. And then the concussion, it also involves more. All right, some of that may be related to the emotions that may have occurred before this event. Maybe before the game, their spouse told them they wanted a divorce. Maybe someone close to them died, and then they're going to go out and play this game, and they may encounter a concussion. And so it becomes really not just a whole body event, but a whole person event when we include that physical trauma, potentially emotional trauma, and potentially also spiritual trauma. So it's not unusual for people to ask themselves silently or out loud, why God, why did this happen to me? That can also be part of a concussion. And with our training, we are able to support people through those different pieces if they are indeed involved. All right, so what I would like to do, we're not going to be using these for polls. Originally, that was what we wanted to do, but there was a bit of a time crunch going on. So you can just silently ask yourself, do you or someone close to you suffer from headaches since the concussion? And headaches are the #1 symptom after a concussion. And this is an illustration of the various types of headaches that occur. And what I would like for you to notice is that these headaches involve many different symptoms. All right, and you see here, we've got the visual system with the ocular migraine and the cluster headache here around the eye, migraines. The autonomic nervous system can be damaged during a concussion and can become dysregulated, creating a wide variety of symptoms related to our heart rate, blood pressure, breathing, and the interaction that the autonomic nervous system has with the rest of our body. And this hypertension type of headache that you see here is a type of response or dysregulation of the autonomic nervous system. And then you see, of course, that the sinuses can become a problem. Remember, those are hollow spaces in some of our bones. And when they get compressed, when those bones get compressed, the space can become smaller and it can become misshapen. And there can't be as much efficient drainage. And then, of course, you see the tension headache here. It's often in the frontal bone, and it's also in some of the other, the muscles that attach to the frontal bone. And then it can also occur in some other muscles. And one of the common muscles is the increased tension in the temporalis muscle, which causes a stress response in our system. Let's just take a look at that. It's a fan-shaped muscle that you see here on top, and that it can respond with tightening and holding on to its tension when we are in fear or in a state of stress. You learned at Cranial 1 that the temporalis muscle is innervated by cranial nerve 5, the trigeminal nerve, and that is a part of our sympathetic nervous system, which is the fight or flight muscle. And we will tend to have that be stressed. So when we look back at these pictures, you see, as many of you mentioned, that the eyes were all closed, and you see the wrinkling of the muscle that does that. And it's basically, unless somebody does some sort of program to separate them out, if you just squint, well, first, go ahead and just take your fingers and place them over this muscle on your own body. And what I want you to do is to clench your teeth and feel that contraction. And this is an evolutionary response, right? And it's unconscious, is that when we are stressed, when we are in a fight or flight mode, we will clench our teeth. And when there has been a concussion, there is a surge of cortisol that is released by the adrenals that puts us in that fight or flight state. And this can be a sustained contraction. And so one of the things that we can do, and we have some individuals here that are lay people, and this is a great technique for you to do, and you can try it right now if you like, just by placing your hands over your lower jaw. And for those of you that are lay people, we use a very light touch. And when we're first learning this light touch, I often suggest to people that they just place their hands there and just think, just have a thought of gently tractioning it inferiorly and hold that there. And for those of us that are practitioners, we have the option here of doing some fascial glide over a tense muscle. And we're using the temporalis here right now because it's common. And so if you would like to right now, you can place your hand in this orientation of the temporalis muscle and go ahead and evaluate the fascial glide in a posterior superior direction and an anterior and inferior direction, and test the other side and which side has the most mobility, the direction of ease. So while the lay people are working with their TMJ self-help technique, you can place your hands and test and just hold with again, our light touch in the direction of ease and wait for that muscle and its fascia to lengthen, right? And that, the reason why we use the light touch, of course, and this is super important after concussion, when people are in this sympathetic fight or flight state, is that when we use a light touch, we are engaging the inner physician, the body's self-correcting ability. And if we were to use more force, that is typical of some manual therapies, is that would engage the self-defense system, which is what we're trying to help relax here. So, and then of course, after you do that fascial glide, you can check and see how, if you now have more motion going in the direction of the barrier or the opposite direction. So that's a technique that we can use. And next, we're going to talk a little bit about dizziness here. So do you or someone close to you experience dizziness since the concussion? Okay. And dizziness can come from a couple of different places. Where we're first going to look at it is from the structures in the inner ear. And here you see the structures that are in the internal auditory canal. You see here the semicircular canals, which are reporting information about rotational movement. Then you have this structure, the utricle, which is reporting about linear motion, and the saccule here, vertical motion. And this part here is the cochlea, which is responsible for hearing. And you see the nerve that is going to and from these structures, the vestibular cochlear nerve. And this entire structure is referred to as the labyrinth. And the information from these structures is traveling along the nerve and reported into the brainstem to the vestibular nuclei. And then it's not super simple because there's many pieces that are involved. But what I would like for you to notice is that sensory input enters a place in the brain, which is the brainstem and the cerebellum, and the information there, this is for central processing. It gets the information about where the body is in space, and then it sends out motor output to have the desired movement that is necessary to stay upright and to stay safely upright. And if this labyrinth has been injured, that communication can be inaccurate. All right. And of primary interest here for us as craniosacral practitioners is I want you to notice here, this is the temporal bone, and you see the labyrinth here in shadow. It is inside this internal auditory canal. And this part here, this is the petrous portion of the temporal bone. And you may recall from cranial 1 that on day 3, you learned about the intracranial membrane and specifically the tentorium that attaches onto this petrous portion. So when we come back here, you see in this particular image, part of the tentorium has been cut away, but it is attaching here along this petrous ridge, and that labyrinth is sitting underneath in that canal, the inner ear, right in here. And again, we see it in shadow here, and this is the petrous portion. And why this is so interesting for us is that we recall Wolff's Law, which we learned in cranial 1, that bone changes according to the forces applied to it over time. And that dura mater that is attaching there, that is the fascia of the nervous system. During a concussion, it also gets injured. You may recall from day 3 of cranial 1, you were shown slides of Dr. Upledger's original research showing you thick tension lines in the membrane that in this particular example could change over time through Wolff's Law, the orientation of this petrous portion, the orientation of the entire temporal bone, that would cause some, potentially cause some inability for those structures to operate optimally. In addition, Wolff's Law, depending on how those forces are applied over time, can narrow that internal auditory area. And that could cause compression on this, these structures, including the nerve. And we know that we are going to probably pick up a problem with the temporal bones with our first vault hold, and also with our temporal evaluation of the rotary component and the medial lateral motion. And then, of course, we remember that before we enter the head, or, well, let's see, here would be the treatment, our osseous treatment with the unilateral ear pull and our membranous release, which is the fascia of the nervous system, right? The bilateral ear pull. And then we recall that we do want to make sure that the thoracic inlet is released first, and that the occipital cranial base is released to make sure that the metabolic waste can drain out from the release of those restrictions. All right, so next let's talk about vision. Do you or someone close to you have challenges with vision since the concussion? So these can include light sensitivity, blurred vision, double vision, difficulty reading, difficulty scrolling on a computer, having that ocular type of pain, headache, or nausea. Okay. And what we want to look at here for this particular segment are the muscles of the eye. These attach to the eyeball, and you were first introduced to these in cranial 1 when we were studying the sphenoid and the foramina through which these nerves that are going to the muscle are traveling through. And when we fixate our eyes on a particular spot, it allows us to identify the object and where it is in space. And this requires coordination of these muscles. And they have to be coordinated in a variety of ways in relationship to how our body is moving in a particular moment in time. And so we'll just take a look here at some of these visual fixation systems to understand how they are supposed to work, and then how they can be challenging for someone who has some persistent concussion symptoms. So there's some fixation system referred to as the smooth pursuit, which is the ability to follow a moving object. All right, so you might be walking down the street and you see someone interesting, and you're going to follow their movement as they're crossing the street. The cicadas, they are the ability to rapidly move the eyes from object to object for a quick moment. So this being able to rapidly move the eyes in a variety of positions. If you can imagine, it's summertime and a fly is annoying you during the summer, and you've got your fly swatter, and you were like trying to track the next place where this fly is trying to make his latest getaway. That is a coordinated eye movement. Vergence is the ability to adjust to different viewing distances. And then here we have our visual ocular reflex, vestibular ocular reflex, that is stabilizing the eye gaze during neck movements. All right, so if you are going to be moving your neck, all right, what happens is that that rotation of the neck gets detected by the semicircular canals that we spoke about, and they are going to be interacting with the nerves to these muscles. And if the eyes cannot stabilize while we're turning our neck, it can be problematic for a person with persistent concussion symptoms that involve the eye. They may have some difficulty reading, which can definitely happen after a concussion. And then lastly, you see accommodation, which is the ability of the eyes to maintain a focused image as the distance varies, right? And what I would like to just kind of go over a little bit with you is that those muscles are, as we saw, they are attaching to the eyes, and they do all kinds of movement. And actually, when I teach about these muscles, we are all familiar with these muscles. If you can recall when you were a teenager, that when your parents were giving you or trying to give you some words of wisdom or advice, and that we as teenagers would roll our eyes. And when we roll our eyes, we are using all of these muscles. And it's interesting, around the world, it doesn't matter where I've ever been, everyone as a teenager rolls their eyes at their parent as a teenager, which makes me laugh. So those muscles need to be coordinated, and they have a optic nerve that is behind the eyeball that is traveling to the back of the brain here outlined in blue. So one of the ways that we can treat this area, and this one, we would ask that the lay people sit this one out, this little practice session, but those of you that are therapists, if you take your long finger and place it over the medial canthus of your eye, and your index finger over the lateral canthus, and what I would like for you to do is just to invite the craniosacral rhythm into your finger pads. and ask you square, are they symmetrical? Quality, is it easy or hard for the eyeballs to express the craniosacral rhythm? Amplitude, how far can they roll out? And how far can they roll in? Okay, and just try and remember just for a few moments about what you found. And then with your same hand placement, go ahead and invite the eyeballs to show you their self-correcting motions. So this is like a local regional tissue release. You would be listening for the significance detector. And just take about another minute here to follow those self-correcting motions. Notice your own signs of tissue release as you do that. Listen to the significance detector. And this is one way that we as craniosacral therapists can contribute to helping these muscles balance. Okay, all right. So next, let's talk about neck pain. All right, because neck pain is common since the concussion. And we've already said that persistent concussive symptoms occur in 10 to 15% of concussed individuals. And with whiplash, just in and of itself, without a concussion, those symptoms can persist in 50% of the population. And it is impossible to have a concussion without a whiplash. So a whiplash in some form, not necessarily anterior, posterior, can be a lateral, medial, lateral medial type of whiplash, and anything in between in an oblique manner. Right, and so let's look at this a bit. We know the research is very prevalent about this, is that manual therapy helps the cervical symptoms that are either coming from the neck and affecting the neck, or are originating in the neck and causing headaches or dizziness. We know that manual therapy helps this, and it really doesn't matter what manual therapy you're using. If you are licensed for manipulation, it can help. That can help mobilization techniques, any type of myofascial release. From a craniosacral perspective, we've got a couple of options to work with this. So let's talk first about the cervical spine and concussion in terms of muscle tension in the neck and pain in the neck. So these illustrations are from the Beyond the Dura Cranial 2 book, and these black lines here are showing you, those are representing the fascia that are encasing, in this instance, some organs. This would be the thyroid and the vertebra. Here it is showing you with this pattern that these are muscles that are encased in the fascia. And you see here that also we have vasculature, the carotid artery, jugular vein, and the vagus nerve are in there. And this illustration is showing you that these muscles are attached to the inferior surface of the head. Right, and you can do any type of technique that would be helpful. What we can do is certainly fascial glide. along the trajectory of these muscles and their fascia. And here we get a good look here at the suboccipital muscles, which can be helped through our occipital cranial base technique. And you can also do fascial glide over these individual muscles along their origin and insertion. And also of interest here are these nerves. There are spinal nerves that come out at these levels, C1, 2, and 3, and they have their various names have occipital nerve in them. And you recall from cranial 2 that any of these spinal nerves that are exiting out can be facilitated. And so you can work with a facilitated segment of these nerves. You would particularly find them with the second vault hold with your posterior hand, and also identifying the actual facilitation through the traction of the dural tube. Okay, so that is looking at it from actually what can happen to the cervical spine. And now we're going to look at the cervical spine in relationship to headache and dizziness. And dysfunctions in the neck can cause a headache or dizziness. We'll start with the headache. And when a headache has its origin, and it's also true of dizziness, if it has its origin in the neck, it is referred to as a cervicogenic headache or a cervicogenic dizziness. And so we're going to look here at the cervicogenic headache first. Okay. And so we just looked at this picture, but now we're going to look at it a little bit more closely with some detail here. The important thing for us to remember is that these first 3 cervical vertebrae are the most mobile vertebrae in the spinal column. Okay. And they are, because of that mobility, they are more susceptible to misalignment between, misalignment in general, all right, and specifically what we're going to cover here this evening are the misalignment of the facet joints. So here you see C1, 2, and 3. And right in here, you see the inferior facet of C1, and this is the superior facet of C2. And what we want you to notice is that if you can imagine a whiplash, a hit to the head, thinking back to even some of those still pictures that we saw, is that they can shift in the facets in their relationship with each other, and they no longer are gliding easily. And additionally, those nerves that we looked at before, the spinal nerves C1, 2, and 3 that are exiting out are traversing very close to those facets. And if they get the facets get misaligned, that can compress on these upper cervical nerves, and they can cause facilitation, they can cause compression, they can become inflamed because of those things that are occurring. And these nerves, not only do they innervate these suboccipital muscles, but they also go superior and synapse with the trigeminal nucleus, one of the trigeminal nerves nuclei. And that synapse in that nuclei basically communicates and joins the sensory distribution of that nerve being the trigeminal nerve. And you see here that when that gets activated, that takes up a good portion here of the face and part of the head. And you can see how we might have a frontal headache, or right here on the greater wings. You'll see people, when they have a headache, they'll take their fingers over their greater wings and they will contract their frontalis muscle. Right? You can have also here some symptoms that we haven't really mentioned because we're talking about pain right now, but you might have a patient that has some numbness or tingling that may be coming from activation of this nervous communication here. And then that's not all. Is that these same nerves, in addition to the suboccipital nerves, they are innervating the muscles and fascia of the scalp. Okay. All right. Okay, and we would pick those up probably with our second vault hold. And just to make things even more interesting, those occipital nerves, they basically get around and they enter into the cranium and are innervating the dura, that is the fascia of the nervous system that is lining the posterior portion, the posterior fossa of the cranial vault. So you've got those occipital nerves that can be facilitated going externally to the scalp and then internally into the dura or the fascia of the nervous system here. So working with those nerves can be very beneficial. We, of course, can work with them from a facilitated segment position. Fascial glide may be of assistance in helping to have a mobilization effect on the nerve as well. And then if you are trained in neuromeningeal manipulation from the Broil Institute, I highly recommend that. That can also be very effective on helping to release those nerves. And basically, when they are facilitated, the havoc that they can create on a post-concussed individual. All right. And so the cervical spine can also cause cervicogenic dizziness, but that occurs from a different aspect. It's not the same reason that it causes it. Is that these structures that you see here, the eyes, the otoliths, the labyrinth, and the neck, these are all reporting proprioceptive input into that central processing center in the brainstem. And if any of these areas have been damaged, and we've already gone over the neck, the labyrinth, and the eyes here, they will report inaccurate information to the vestibular nucleus. And it can, let's actually look at the neck here. The proprioceptors, the actual neck has the highest density of proprioceptors in the entire body, because it is reporting about where the head is in space. And that's important for us from an evolutionary perspective, because we use our eyes to be on alert for a potential predator, our ears to hear a sound, our smell, if there is, say, smoke or something that is potentially dangerous. And so these proprioceptors in the capsules of the joint, the ligaments, the muscles, and also particularly in those suboccipital muscles, they are very important. And if they become injured as part of the neck, they are going to be, or if the neck is injured, it can report altered information that isn't really true. Okay, and this can cause dizziness. It is a mismatch, and the brain can't, that processing center can't make sense of what it is feeling, and dizziness may then occur. And the treatment of these cervicogenic symptoms, whether they're coming from, they're causing a headache or they're causing the dizziness, is the same. You can use any soft tissue mobilization or other manual therapy to the neck, and the literature shows that it will be helpful. And we spoke from a craniosacral standpoint about using our fascial glide and working with the facilitated segments. Okay, and I just wanted to take a moment here, because we covered a lot here. And the craniosacral, as craniosacral therapists, we are uniquely qualified for assisting in a whole person recovery from a manual therapy perspective, because we're listening to the whole body. But the recovery from a functional perspective requires multiple disciplines, and a team approach is often needed and is evidenced by the proliferation of concussion programs and specialty clinics throughout the United States. And I'm not sure what is going on in other countries, if that is a similar occurrence. But this, and it's my belief that every concussion program should have a craniosacral practitioner as part of their team. And despite the growing evidence about the benefits of craniosacral therapy for post-concussed patients, is that not all of these concussion programs employ a craniosacral practitioner. But it is important for this team to have a practitioner, so that then when they go into the re-education of function, because there's the eyes, we've all had one-shot wonders, but it's important in many cases of concussion that they functionally are exercised, the eye muscles, all of the parts. All right. And so I wanted to just give a shout out to one of our colleagues, Sally Fryer Dietz. She is one of the 4 authors who published a study on CST, visceral manipulation, and neuromeningeal therapies for retired professional football players who had persistent symptoms. And to the best of Sally's knowledge and my knowledge, she is the only, in the United States, she is the only craniosacral practitioner who founded and designed a multidisciplinary and integrative concussion recovery program in the United States. And so that's a big deal. Her practice is a private, independent medical practice with a comprehensive approach to helping all ages recover from concussion. And it's so successful that she is actually looking for more craniosacral practitioners to be part of this multidisciplinary team. She's looking for a couple more that have a PT or an OT license. So her website information and how you would contact her if you're interested through her website. that would be in the handout. So I just really want to thank her because she's really taken craniosacral therapy to a new level by having it integrated into a recovery program. Okay, so next, let's look at medications. Some of you may have had some medications prescribed for you or that have had a concussion. But what can happen with medication is that some of the side effects of common medications that are prescribed for a particular post-concussion syndrome have the side effect mimics another symptom of concussion. So, for example, a post-concussed patient with migraines may develop dizziness that is a side effect of the medication for the migraine. And you and I might be working with this patient thinking, oh my gosh, they have dizziness as a part of their persistent concussion symptoms, when indeed they don't. It's coming as a side effect from their medication. So the takeaway here is to read the insert carefully and also remember that those of us who are not physicians, which is the vast majority of us, is we do not manage medications in any way. We don't prescribe them, obviously. We don't recommend or suggest in any way to a patient to stop the usage or change the dosage. Okay, because it's not within the scope of our practice. All right, so now let's briefly look at the gut. Do you or someone close to you experience any symptoms of gut inflammation? And you see some examples there: bloating, gas, food sensitivities, diarrhea, constipation, acid reflux, nausea, heartburn. Okay, so let's talk about this a bit. We're going to be talking about the microbiota, gut, brain axis, and concussion. And the gut has its own nervous system separate from the central nervous system. It also has input from the central nervous system, but they operate independently and they communicate with each other, letting them each know what the other is doing. And that is how it typically operates. And they communicate via the vagus nerve and, of course, the neurotransmitters of the vagus nerve. And many of the messages which are being sent along the vagus nerve are manufactured. Many of the neurotransmitters are being manufactured by these friendly bacteria, the microbiota in the gut. And what ends up happening here is that when there is a concussion, the inflammatory response of the concussion that occurs in the brain, remember, it has been hit and it has the metabolic activity, their balance has been interrupted, and there's inflammation. And that inflammatory response is sent and arrives at the gut within 6 hours of the hit. Okay. And what then happens, all right, is that the gut barrier from that inflammation, it becomes more permeable. Okay, the gut mucosa gets altered by this inflammation. And so this is very schematic here, but just look here at this area. This is the gut mucosa holding the walls of the intestine together. And then as that inflammatory response happens, you see that that permeability increases. There's a widened space. And as a result of that, larger molecules leak out. These include bacterial toxins and undigested molecules of food that are leaking out of the gut, and the immune system has gets activated again because it does not recognize these undigested food particles. They are taken care of within the gut. They're not supposed to be out in that interstitial space. And so we get an inflammatory response that sees these as the enemy, so to speak, and they go after these particles, but they can't get them all. And those particles end up in the brain because the blood-brain barrier has been injured. Okay, and then once that happens, it's like danger, danger, Will Robinson. Another part of the body system becomes activated, and this would be the endocrine system. So the endocrine system senses danger, and it sends orders to the adrenal glands to circulate more cortisol. And then that amplifies that already happening sympathetic fight or flight state. Okay, so let's just briefly talk about the endocrine system here. I'm going to just go ahead and jump here to the hypothalamus. This is the part of the brain that issues the orders to the pituitary to release the hormone, which is the chemicals that help our bodies to operate optimally. And so the hypothalamus instructs through this stalk, the communication through this stalk here into the pituitary, what hormone to release, the dose of the hormone, what organ it should go to, and it does this through this particular stalk. Okay, now the sphenoid is home to the pituitary gland. Okay, this pituitary is sitting inside the sella turcica of the sphenoid. Can you imagine what could happen here if the sphenoid has got a lateral strain pattern where it is moving in a straight line, or it has a torsion or a side bending dysfunction, how that can distort not only the pituitary, but the stalk. It can twist the stalk. There can be compression. And endocrine dysfunction is something that occurs after a concussion. In women, it can show up with some dysmenorrhea, men with erectile dysfunction. These can all occur as a result of a concussion. And then lastly, we're just going to quickly go over sleep. And basically, people will experience either difficulty falling asleep, difficulty staying asleep, not being in the regenerative stage of sleep long enough, sleeping more or less. Okay, and the sleep disturbances associated with concussion involve a convergence of multiple systems here. So with the nervous system, we've already talked about how facilitated segments interfere in optimal functioning of the brain. The circadian clock, there's been recent research that shows that they were able to isolate the gene that helps control the body's clock, which is a 24-hour biological system, but it's in every cell. Okay, so it affects every cell. The glymphatic system, most of us have heard about that, about the specialized system in the brain that delivers nutrition and clears out the waste products, that is most active during sleep. Sleep is very important for that system. And then we've also talked about the autonomic nervous system and that dysregulation. We've already mentioned the endocrine system and the orders from the hypothalamus to circulate more cortisol. And then the limbic system is our emotional brain. And we've all experienced worrying about something, having fear type of emotions, and how that can, and stress, can interfere with our sleep. And depression and anxiety are often associated with concussion. And from a craniosacral perspective, helping someone have a good night's sleep supports the healing of the brain. It's very important. And we can use all of the techniques from Cranial 1 and 2 to help open up that cranium, to give the brain more space in which to function. And from an SER perspective, someone may have had the beginning of a sexual assault occur while they are asleep. Here in Florida, not too long ago, I think it was a 14-story high-rise collapsed at 1:30 in the morning. And some of those people that survived, that occurred while they are sleeping. And one of the things that we can offer for our patients, besides our cranial techniques, is to offer them some assistance with their sleep disturbances by helping to change their external, or to control their external environment. And this is known as sleep hygiene. This is one of your handouts that you can feel free to give to your patients, but please give attribution to the Sheltering Arms Hospital Concussion Program. That's where I received them. All right, so it's not the end just yet of your learning, because we have our patients that are our best teachers. Dr. Upledger taught us that and repeated it multiple times. And then also there is the CranioSacral Therapy Applications for Concussion class, which will delve more deeply into these topics and many more, both with lecture and labs. And just again, remember, your client is your best teacher. And when you attend any manual therapy class, you are adding to the library of your hands, and that enables you to, your best teacher, the patient, their inner physician, to communicate to us, okay, when we've learned something new. Then I want to remember John Matthew Upledger, Dr. Upledger's son, who entrusted me with developing the CranioSacral Therapy Applications for concussion. And lastly, I want to thank Dr. John for bringing us this beautiful therapy that has changed the lives of many.